Hello, and welcome to our program titled Charting a Course for Cost-Effective Improved Outcomes in Hemophilia Management. I'm Douglas McKell with Impact Education, and I am pleased to be joined by Dr. Ed Pizzala, MD, National Medical Director, Pharmacy and Policy Strategy for Aetna, and Dr. Michelle Whitcott, Doctor of Nursing Practice, Bleeding Disorders Nurse Practitioner at Munson Medical Center. Dr. Pizzala and Dr. Whitcott are members of the Comprehensive Care Sustainability Collaborative, or CCSC. The CCSC represents a partnership between the National Hemophilia Foundation and Hemophilia Treatment Center and payer stakeholders, seeking to promote quality care and cost effectiveness in hemophilia management by supporting the sustainability of the comprehensive care model. CCSC members consist of a prominent group of Hemophilia Treatment Center directors, clinicians, and administrators, along with payer, managed care, medical, and pharmacy directors, as shown here. The CCSC, formed in 2014, has reviewed relevant data and shared ideas in an open forum. The primary objectives of this exchange were to identify and overcome communication gaps between providers and payers pertaining to the management of hemophilia patients, and to elicit input from both a clinical and a business perspective. The HTC's comprehensive care management and documented ability to achieve quality care and improved outcomes has served as a focal point, as well as payers' perspectives on the specialty drug forecast and the management of hemophilia. The CCSC's aim is to develop a framework for pilot programs to be replicated across the United States between payers and HTCs that facilitate cost-effective hemophilia management, integrating the HTC comprehensive care model. 2 consensus meetings were convened in 2014, and a 3rd meeting is being convened in 2015. The result of these meetings thus far has been 2 distinct sets of HTC and payer-reported metrics, designed with the input of all shareholders involved in the initiative. These metrics will be used to facilitate data sharing between HTCs and payers, thereby providing a foundation for pilot projects currently underway. The CCSC objectives are: 1. Advance the collaboration between payers and providers to provide high-quality hemophilia care to patients that is both effective and reimbursable. 2. Collect data validating collaborative relationships between payers and HTCs that will ultimately benefit all parties involved, including patients and members. 3. Implement initiatives throughout the United States between payers and HTCs that support the sustainability of HTCs and the comprehensive care model. The key premise of the CCSC is that the right alignment of stakeholders drives the best possible patient outcomes. The U.S. network of Hemophilia Treatment Centers plays an important role by collaborating with other healthcare stakeholders to deliver quality and cost-effective outcomes for patients with hemophilia. The initial findings and recommendations from the CCSC are reported in a white paper, which is available at www.ccschemo.com. White paper highlights include an analysis of the current state of hemophilia care and the benefits of the comprehensive care model, expert feedback and consensus recommendations to facilitate cost-effective hemophilia management integrating the HTC comprehensive care model, information regarding competitive factor pricing, and a thorough explanation of the role of 340B pricing in covering operating expenses and funding ancillary services provided at HTCs. Recommended HTC and payer reported metrics to facilitate information sharing across multiple groups of healthcare stakeholders. To begin the discussion with our 2 experts, I'd like to ask Dr. Whitcott to provide some background on the fundamental basis and purpose of the CCSC initiative. Can you please explain the historic role of HTCs in hemophilia management?
Hemophilia is an X-linked recessive bleeding disorder that's caused by a functional or a quantitative deficiency of one of the coagulation proteins. Factor VIII is hemophilia A, whereas factor IX is hemophilia B. Both of these lead to an inability to form a clot that leads to spontaneous bleeding following trauma or surgery. Current prevalence in the United States is about 20,000 males across all ethnic and racial groups. Hemophilia A is about 1 in 5,000 live male births, while hemophilia B is 1 in 30,000 live male births. When we look at clinical presentation, there's about 50 to 70% of persons with hemophilia are considered severe, which means less than 1% of factor VIII or factor IX. They bleed spontaneously about 2 to 4 times per month. 10% of persons with hemophilia are considered moderate, which is 1 to 5% of factor VIII or IX. They tend to only bleed following minor trauma, possibly 4 to 6 times per year. 30 to 40% of persons with hemophilia are considered mild, which again is only 6 to 40% of factor VIII or IX. They may not actually be diagnosed until later in life because they don't bleed as often, usually only following a major trauma or surgery. The 2 to 9-year-old age group has the highest distribution at 48%, whereas the over 65 has the smallest distribution at 3%. Generally, persons with hemophilia are diagnosed before the age of 2. But given our improvement in treatment, the life expectancy can exceed 70 years. Our older patients tend to have many comorbidities, often associated with aging, such as cardiovascular disease, but they also have comorbidities from receiving plasma products when they were younger, such as hepatitis C and HIV. When we look at insurance coverage, 50% of our patients are insured under commercial plans. An HTC is a federally recognized comprehensive hemophilia treatment center that has a multidisciplinary team with expertise in the care of patients with bleeding disorders and whose staff spends a majority of their time caring for these patients. This map illustrates the 8 regions into which the country has been divided under the MCHB grant. Each region contains a core center and also has a regional coordinator and a regional director. These individuals are responsible for coordinating the MCHB and CDC grants, as well as coordinating matters among HTCs within the region and collaborating with other regions as needed. This organizational structure is slightly different for the CDC grant, with the New England states divided into New England as one region and New York, New Jersey, and Puerto Rico as part of a second region. This graph illustrates the significant increase in total HTC patients, the mix of patients by diagnosis, and the increase in patients with von Willebrand's disease and other factor deficiencies, which now compromises about half of the patients receiving care at HTCs. When we think about treatment goals, our approach, and strategies, our main goal is the rapid and effective replacement of the missing coagulation factor. And this is in order to raise those factor levels, to decrease the frequency and severity of bleeding, as well as to prevent the complications of bleeding. We achieve this through comprehensive hemophilia treatment centers being staffed by multidisciplinary teams of experts who care for patients with bleeding disorders. These providers utilize strategies that include episodic or on-demand factor replacement, as well as prophylaxis treatment. Additional functions of the HTC include establishing and maintaining regional and national registries of patients with bleeding disorders so that we can document hemophilia treatment and its outcomes. We also support and conduct basic and clinical research, particularly through participation in collaborative trials, preparation of treatment protocols or guidelines. We conduct pharmacosurveillance. We also cooperate with the competent authorities in designing healthcare policies for hemophilia patients. Comprehensive care for hemophilia is defined as the continuous supervision of all medical and psychological aspects affecting the patient and family. Optimal treatment is based on early detection and diagnosis, the prevention and treatment of bleeding episodes and any complications, especially hemophilic arthropathy, the detection and management of inhibitors, psychosocial and educational support, monitoring for treatment-related comorbidities, and the coordination of care with other providers involved in the management of the patient.
Thank you for that excellent overview of the role of HTCs. What is the end result of this highly integrated, multidisciplinary care in terms of patient outcomes?
For patients receiving care outside of an HTC, the mortality rate increases by 70%, and hospitalization rates increase by 40%. The following need to be considered in the total cost of care: decreased number of bleeds, reduced number of infusions, avoidance of unnecessary emergency room visits, improvements in the patient's quality of life, adherence to the treatment plan, and proper dosing through assay management.
Dr. Whitcop, considering the high value of the comprehensive care model and the vast array of services provided at HTCs, how are these entities funded? Are payers billed for these individual ancillary services?
Federally recognized HTCs have access to 340B pricing. For those institutions who operate a 340B pharmacy program, the funds generated serve as the primary source of revenue. A 340B pricing also allows centers to provide integrated, comprehensive services at an often lower price than some specialty pharmacy vendors. This operating model allows HTCs to provide comprehensive care to patients without billing payers for many individual services. In addition, the HTC integrated pharmacy model, incorporating in-house pharmacy services, allows for the intensive management and monitoring of adherence, utilization, and dose requirements. This model also prevents the fragmentation of care. HTCs provide comprehensive care, which includes physical, emotional, psychological, educational, as well as financial support. They focus on teaching self-administration to promote independence. Typically, this starts by the age of 8. Persons with hemophilia show improved health with reduced costs by lowering rates of unemployment, emergency room visits, hospital stays, and illness-related time off from work and school. Most persons with hemophilia visit HTCs at least annually for comprehensive medical evaluation. Medication can be dispensed by a pharmacy associated with the HTC, and about 70 to 80% of persons with hemophilia are under the care of an HTC. HTC providers include the following experts in the multidisciplinary team: hematologists, pediatricians, dentists, physical therapists, orthopedists, nurses, social workers, and nutritionists, as some examples. HTCs help control the cost of care. Many services are provided free of charge. Expert care limits complications. Multidisciplinary teams minimize emergency room visits. They promote independence. Complete medical histories are readily available, which promotes optimal decision-making. Relationships with expert subspecialists helps with the coordination of care, and PHS pricing helps to control the cost of factor. The HTC model of care is aligned with these payer perspectives on managing low-prevalence, high-cost conditions. Carve-out disease management of a rare disease can work. but only if the aforementioned precepts are followed. Care management is highly valuable, but only if the engagement mechanism is reliable and information can be shared and is actionable. This highlights the importance of clear quality and efficiency metrics, transparency, and consistent information sharing and data reporting.
I'd now like to turn to our managed care expert, Dr. Pizzala. Could you describe the hemophilia disease burden from the payer point of view? Is it a priority to you, and how do you approach the intensive management that these patients require?
Hemophilia represents a significant healthcare challenge, both in cost and delivery of quality care. Hemophilia and other rare diseases are often cost outliers without a health plan turnkey solution. Because of their uncommon occurrence and a lack of defined or known care delivery infrastructure, employers with self-insured plans and their consultants talk about population health, but in medical cost reviews, they often focus on these high cost outliers. Costs of care in rare diseases must encompass total cost of care in a time period and not only select composite costs of some aspects of care. This prevents the tube of toothpaste theory from coming into action, where costs squeezed on one end just bulge and ooze out the other end. Hemophilia is a low prevalence but high cost disease. Hemophilia has a very low prevalence but is a high cost disease compared to other common conditions like diabetes. Hemophilia only has a prevalence of 20,000 patients, but average costs could be over $300,000 per year per member. The cost of hemophilia care can be very high. It's a combination of prevalence rates and costs for the drug. Prevalence rates per 100,000 males for hemophilia A and B is rather low. In commercial plans, it's 11 for hemophilia A and 1.8 per 100,000 for hemophilia B. For Medicaid, it's 21.2 per 100,000 for A and 3 per 100,000 for B. Prevalence rate of inhibitors, more serious complications and treatment, is 2 to 9% for hemophilia A and 1 to 4% for hemophilia B. Prevalence rate of inhibitors and more serious complications of treatment is approximately 2 to 9% for hemophilia A and 1 to 4% for hemophilia B. Hemophilia A drug costs are 76% and 86% of total claims costs for commercial and Medicaid respectively. For hemophilia B, drug costs are 70% and 48% of total claims costs for commercial and Medicaid respectively. Hemophilia drug spending is projected to increase 79% by 2016. Drivers of spending trend include increased utilization, greater use of prophylactic regimens, and rising drug acquisition costs. There are a number of challenges for hemophilia care management in managed care. These include treatment access and quality, and the approaches to improve this include integrating hemophilia care in network management and medical management strategies. Establishing relationships with HTCs, specialty pharmacy, and specialized medical providers. Another challenge is care management. And an approach can be to consider how to coordinate multidisciplinary outpatient and home-based services. There are challenges in cost management, with the approaches being to consider cost-effective approaches for administration of factor replacement while keeping in mind the individualized treatment needs of each patient. Further challenges occur in pharmacy management, and the approach is to evaluate all services required to manage hemophilia, secure cost-effective and timely factor replacement services for routine and emergency needs. Another challenge is risk management, and the approach is to identify financing solutions, for example, risk adjustments and carve-outs, to ensure member access to care. The final challenge is patient involvement, and the approach is to include members in decisions impacting their care, support member involvement in self-management, and facilitate social support networks.
Thank you, Dr. Pizzala. Payers have obviously worked with HTCs to some degree or another already, but could you expand on exactly where HTCs fit into the management of hemophilia as far as payers are concerned? What's preventing a more integral or exclusive role for these centers of excellence?
Very little information sharing currently exists between HTCs and payers, resulting in a lack of awareness on the part of payers. These are issues that the CCSC initiative seeks to address by promoting collaboration and data sharing between HTCs and payers.
Dr. Pizzala, to this end, what were the key findings from your initial experiences as a part of the CCSC consensus meeting?
Payer representatives were impressed with the data reporting capabilities of HTCs, which will serve as the foundation for future collaborative efforts. The diverse array of currently unbilled ancillary services provided by HTCs also serves as a selling point for the centers in their discussions and contract negotiations with payers. Most payers are open to the notion of partnering with HTCs in the care of these complicated patients, given the fact that costs are comparable to care delivered outside of HTCs. Data reporting, as a function of future mini-pilot initiatives, should serve to support this fact.
Thank you, Dr. Pizzala. I would like to ask our experts to both review the HTC and payer-reported metrics, and where applicable, provide some of the rationale for individual metrics. Dr. Whitcott, could you begin with the HTC-reported metrics?
CCSC recommended HTC-reported metrics include the number of joint bleeding events per month as a surrogate for joint-related surgeries or other hemophilia-associated claims, prescribed factor dose as units per kilogram per dose, number of prescription units ordered versus units dispensed, number of prescription units dispensed if the HTC supplies the factor concentrate, the mean percent from the prescribed dose, bleed-related days of school or work missed as a secondary phase of patient-reported outcomes, and number of all types of HTC encounters per patient, and this includes clinic visits, telephone contacts, telemed contacts, emails, and text messages.
Thank you, Dr. Whitcott. Dr. Pizzala, could you review the recommended payer-reported metrics?
The recommended payer-reported metrics include units utilized and cost for each unique factor as a means of accounting for the number of inhibitor patients, the number of prescription units dispensed if the payer requires use of non-HTC-based specialty pharmacy for provision of factor concentrate, the cost of factor use per month per unique patient, the number of hospitalizations with a primary or secondary diagnosis of bleeding and associated cost of hospitalization, the number of emergency department visits with a primary or secondary diagnosis of bleeding and the associated cost of ED visits, and the total paid cost per patient with a hemophilia bleeding disorder diagnosis.
Thank you, Dr. Pizzala. Both of these CCSC proposed sets of metrics provide an ideal starting point for pilot initiatives. Again, the measures will be validated in these small pilot initiatives, meaning the final metrics may vary after the first phase of reporting is completed. In addition to facilitating improved information sharing between HTCs and payers, what are the benefits of ultimately incorporating the finalized metrics from both of your perspectives? Dr. Whitcott?
These metrics allow treatment center and health plan leadership to collaboratively improve quality of care while reducing waste and inappropriate overutilization of healthcare resources for their patients with bleeding disorders. By reporting quality performance, HTCs have a valuable selling point for network inclusion in their dialogue with payers.
Thank you, Dr. Whitcott. Dr. Pizzala, would you respond?
Eventually, this information can be used to identify the top performing HTCs and contract accordingly with such institutions providing the highest quality care. Information gleaned from this data collection and reporting will also allow plans to provide more granular detail on high-cost patients to their customers, for example, healthcare purchasers, employers, employer groups, etc.
Thank you, Dr. Pizzala. Building upon the momentum generated by the development of these quality metrics, the next steps of the ongoing CCSC initiative are already underway. As the initial stage of the HTC payer pilot projects, selected HTCs across the country have already begun to report data that is currently collected and analyzed. Similar participation on the part of health plans is also occurring and will lead to the development of standardized evaluation and measurement tools. These tools will then be used to monitor and assess the progress of CCSC-based pilot programs. Furthermore, Pilot program outcomes will be analyzed and disseminated in the future through professional meetings and publications. Although several payers have already demonstrated interest in participating, additional plans are welcome to find out more about the initiative and enroll in the program at any time. Benefits of such participation include access to extensive hemophilia-related outcome data from network HTCs, increased connectivity with HTC directors and other plan managers seeking more rigorous standards in the care quality and cost containment for hemophilia, and national recognition for a commitment to quality improvement in hemophilia management. If you are interested in participating in one of the pilot programs, you can either send an email to ccsc@impactedu.net or go to www.ccschemo.com for further information. Additional hemophilia education and resources can be found by going to the National Hemophilia Foundation website at www.hemophilia.org and www.managedcarehemo.com, an educational website devoted to hemophilia education for payers and managed care professionals. Before closing our discussion, I'd like to ask each of our faculty experts to summarize one or two key recommendations for healthcare stakeholders to consider that will help improve the overall quality and cost effectiveness of care for patients with hemophilia.
Data sharing will help to create a dialogue between the hemophilia treatment centers and payers to improve both the quality of care and the cost of care for members with hemophilia and bring that care into the 21st century.
I agree. I think that the communication and collaboration between payers and hemophilia treatment providers is going to be vital to improving the quality of care for persons with hemophilia as we move forward into the 21st century.
I would like to thank our faculty panel for their very insightful and very valuable recommendations.